Hello, and thank you for joining the Centers for Disease Control and Prevention's Preteen Vaccine Adolescent Immunization webinar. Today's webinar is entitled HPV Vaccination, Quality Improvement Projects and Implementation Science, Working Together for the Win. Today you'll hear from three exceptional presenters, Dr. Brian Mittman of the Department of Veteran Affairs, Dr. Alix Casler, Medical Director of Pediatrics for the Orlando Health Physician Associates, and Redwine, Clinical Management Consultant for WellStar Health System Medical Group. Before we begin, I just want to remind you of a few housekeeping items. First, all participant lines are muted. Second, we are recording this webinar and will notify participants when the recording and presentation slides are available online. And lastly, there will be a question and answer session after the main presentations. You will enter your question into the chat panel of the ReadyTalk mainframe on your screen. I will now turn the webinar over to Dr. Mittman.
Thank you, and thank you to the attendees today, as well as CDC for inviting my participation. I've listed my various affiliations on this title slide. My role in our program this morning is to provide a relatively brief high-level overview of the field of implementation science, and attempt to explain what the field is, what it has to offer us by way of insights and guidance, and how we can use some of the tools and approaches and insights from implementation science to achieve our overall goal, and that is improving vaccination immunization performance. So let me begin with a very brief background and overview, introduction to implementation science. It begins with a very simple depiction of the way in which we hope research will proceed from basic science into clinical research that develops new treatments and strategies for preventing and managing and curing disease. And we hope that the results of that clinical research, such as innovative, effective vaccines, will lead quickly to improved health processes and health outcomes. That is not often the case. These pipelines are meant to display and illustrate different paths that research findings in output can follow. Sometimes we see results of basic science research or clinical research published. They sit on the shelf, and oftentimes that's appropriate. Because we often do see findings that emerge from research that don't necessarily have any immediate application. In the case of basic science findings, we'll sometimes learn new things about human physiology, which again don't offer any value in developing new prevention strategies or cures. In the case of clinical research, oftentimes we develop innovative treatments that in fact don't prove effective following research and testing in humans. The harms outweigh the benefits, and those findings too should be published and sit on the shelf. The pipeline in the efforts to accelerate translational research, as it's often called, are meant to focus on the arrows that are depicted at the bottom of this slide. That is, findings that do emerge from basic science or clinical research and are published and sit on a shelf despite considerable benefit and value. So the field of implementation science is one form of translational research, type 2 translation, that is meant to accelerate the flow of beneficial output from clinical research to achieve improved health processes and outcomes. In other words, to overcome the so-called translational roadblock, to eliminate the number of occurrences in which a successful clinical research is published and is not adopted rapidly enough by the health system, and as a consequence does not benefit patients in as rapid a manner as it could. This slide is another way of depicting these different forms of research, translational research. Because there are two types of translational research, we often use the word implementation science or implementation research to capture the research activity that helps us to identify and overcome barriers to the appropriate adoption and delivery of effective clinical innovations. And that, again, is the right-hand side of this diagram. This slide provides a definition of the field of implementation science that Martin Eccles and I had adapted from previous definitions. This is from the introductory editorial in the journal Implementation Science that we established about 10 years ago. It describes implementation science or implementation research as a study of methods to promote the uptake of research findings and other evidence-based practices or innovations into routine practice in order to improve health services. The field also, as the definition states, includes the study of influences on healthcare professional behavior and organizational behavior. We sometimes refer to this as the basic science of implementation science or implementation research. The idea that we attempt to understand how healthcare services are delivered, how healthcare delivery systems and community agencies are structured and how they operate, and we use those insights in order to help identify and overcome barriers to rapid adoption of effective practice. We have what we sometimes label the Tower of Babel problem in this field. This is a list of some of the terms that you may have seen or may encounter if you begin to explore the field of implementation science in the published literature. Much of this work is labeled knowledge translation or translational research. We see technology transfer, quality improvement. These are all labels that describe a very similar body of activity. And this does, of course, represent a bit of a barrier and a challenge to those of us working in the field in our attempts to publicize our activity and our findings. But again, for those who do wish to explore the field, you need to be aware of these other terms and labels. We often encounter colleagues, especially on the healthcare delivery side, practice and policy leaders who ask us as implementation scientists how our field relates to or differs from the field of quality improvement research or improvement science. There is a fair amount of overlap, but again, those who are interested in these fields need to have a basic understanding of the differences and the relationship so that you can know how to use the findings and the insights, the guidance from the fields. Among some of the differences are the fact that quality improvement or improvement science tends to focus on very specific problems in a specific setting. The approaches that are often employed rely on rapid cycle iterative strategies, rapid cycle improvement, rapid cycle evaluation. But again, the basic idea is that improvement science is a set of tools and approaches that we use to solve specific quality problems in a given organization or a given setting. The field of implementation science, on the other hand, attempts to be broader, more generalizable, more scientific. We often focus not on a specific quality problem, but a broad quality or implementation issue or goal. We will often use not a rapid cycle iterative approach, trying different strategies until we achieve success, but instead we'll try to identify a fixed approach. And we will try to deploy that approach, that implementation strategy, across multiple sites, trying to rely on theory, trying to attend to contextual factors, and examine some of the mediators, moderators, and mechanisms. I realize these are somewhat specialized research terms, but again, this gives you a sense of the differences. Implementation science often aims to develop generalizable knowledge with universal application as to whether the field is succeeding in that endeavor and whether it's possible to succeed is another question. But again, these are some of the key differences between these two largely complementary and overlapping but somewhat distinctive fields. Some of the key insights that the field of implementation science has generated, as well as improvement science, that provides some guidance to those of us trying to improve care and trying to improve the adoption and beneficial use of clinical innovation, include the finding that clinical practices tend to be highly stable. They're very slow to change. We sometimes see the term clinical inertia used to describe this phenomena. There are, of course, some exceptions. We will sometimes see new technologies spread very, very rapidly. as opposed to the majority of new innovations that spread very slowly and for which there is a fair amount of resistance. We also know that clinical practices and practice change tends to be highly variable, highly heterogeneous. We will see some settings or some new innovations become adopted very rapidly in some settings but not others. We know that the barriers to practice change and adoption of innovations tend to be numerous and tend to be found at multiple levels, and I'll come back to that multi-level concept in a moment. And we also know that simple practice change strategies such as educating physicians or providing financial incentives or developing and disseminating computerized reminders or mailed reminders, each of these single practice change strategies tend not to be effective. The field has shown us that we need to deploy a package or a coordinated portfolio of multiple practice change strategies in order to address the multiple barriers that occur at multiple levels. And only by combining strategies that target those barriers can we expect to see a significant change and improvement in practice. So I mentioned the multi-level nature of barriers and the multi-level nature of the needed practice change strategies. We know that in most cases, and this is true of course of adolescent immunization, that there are multiple influences on clinical decisions and practices. These occur at the point of care. They include both the physician knowledge and attitudes and beliefs as well as patient knowledge, attitudes, beliefs, and demands. There are influences that occur at the level of the team, the organization, the community agency or clinic or hospital. We're seeing the growth, of course, of integrated delivery systems, Kaiser Permanente and others, as well as smaller systems that are evolving into a larger integrated system. These systems have their own policies, organizational policies, fiscal policies, leadership and culture, and these represent key influences as well. Moving still higher up the multiple levels, we get to professional norms within the physician community, the nurse community, and the other professions. And we know at the level of communities and society that patients and businesses and other stakeholders exert influence over clinical practices as well. And then again, moving to a higher level still, we have various regulatory factors that influence clinical practice. Now, we often like to contrast the current situation with what we sometimes label 1950-style medicine, when we had physicians practicing for the most part in solo practices or in very small groups, where much of the decision-making influence stemmed from those own physicians' knowledge and attitudes and beliefs. And back in the 1950s, efforts to improve quality of care, had there been interest in conducting such efforts, would have focused primarily on the individual physicians. But the situation today, of course, is very different, and we do need to be aware of and take account of the numerous influences on clinical practices that occur at these various levels. And when we look back at the history of quality improvement to try to understand where we've succeeded and where we haven't, most of the quality improvement projects that have been conducted and published tend to focus relatively narrowly on only one or two factors or causes or influences on clinical practices, or one or two causes of quality gaps. And as a consequence, we see a fair amount of effort, but only occasional and limited impact. Physician education strategies, for example, focus on only one barrier or one factor that influences practices. And if we do deploy a physician education strategy and evaluate that strategy in a research project, the typical finding of such a project is that the physician's knowledge and attitudes changed, but there was no change in the clinical practices. The practices, again, are determined not only by physician knowledge, but by many other factors as well, and our quality improvement or implementation strategies need to address them. Now, the remainder of my presentation, I will walk relatively quickly through a set of 8 slides that briefly describe each of these different domains of influence or determinants or factors that influence clinical practice. This is a list that we might view as essentially a checklist. That when we are faced with a quality gap, an implementation problem, an area of clinical practice for which we would like to achieve improvements, that we need to think through each of these sets of domains, these sets of factors, and try to understand whether they represent barriers to practice change, and if so, what kinds of intervention activities would be needed as part of our integrated portfolio in order to achieve improvement. And again, I'll go through these quickly and hope that those of you with an interest will have access to the slides and can spend some time on your own reading through them. We know that, especially for physicians, but other professionals as well in the healthcare field, we need to begin with evidence-based practice standards or guidelines. It is very difficult to achieve change in clinical practice without a very strong, solid, legitimate evidence base. We need to know that the changes that we are promoting, advocating, are supported by good evidence, and that it's evidence that is consistent with and accepted by the physicians or the other clinical communities that we are targeting. The second condition derives directly from the first, and that is clinician and staff knowledge and skill. In order to convince physicians and others to practice differently, to deliver a new service, they need to have the requisite knowledge and they need to have the skill required in order to practice on that knowledge. The third condition is something that is somewhat unique to the professions, and that is the issue of professional norms and peer influence. We know that physicians often tend to practice in a manner that is consistent with what their professional peers are doing. There's a fair amount of uncertainty in clinical practice. Oftentimes the evidence is ambiguous. Oftentimes there may be 2 or 3 different practices that seem to be supported by the evidence, and we tend to see professional norms arise that indicate the appropriate way to practice. Those norms are disseminated. Those norms are spread through peer influence processes, the use of clinical opinion leaders, academic detailing, and other strategies. So this, again, is another condition that we need to see present in order to expect a higher likelihood of practice change, that the professional norms are consistent with the clinical practice that we are advocating. We also know that physicians, as with others, often face competing demands, have a long list of goals that they wish to accomplish, and they need to make decisions on a daily basis or even on a patient-by-patient basis as to how to prioritize their time and their effort. And when we see the existence of external pressure, external incentives, various performance initiatives or performance measurement, these provide some of the outside interest and pressure and expectations that direct the attention of the clinicians and the staff and increase the likelihood that they will focus on a given performance problem and a given clinical goal as opposed to others. So again, another condition that needs to be present to increase the likelihood of quality improvement or practice change. Patient acceptance is an issue that is often present and is especially problematic in the case of HPV vaccination. We know that if physicians are highly supportive of a given practice and yet their patients resist, that we're unlikely to see significant practice change. So the integrated, coordinated portfolio of quality improvement strategies or intervention components that we need to design and deploy, we need to include elements that simultaneously address patient acceptance at the same time that we are working on the staff and the clinicians and working to overcome other barriers. Even if we have the first 5 conditions in place, quality improvement is not as likely unless we can provide evidence that current practices are inconsistent with the desired practices. We will often try to promote the adoption of a new clinical practice to a group of physicians, and they will respond by agreeing that that practice is desirable, that it is appropriate, and they will respond by indicating that their current practices are consistent with the evidence. If we provide them with data that indicate that they are not adhering to the recommendations, their motivation and their likelihood of change is greater. So again, this is another necessary condition. Two more conditions. One is what I call etiology of deviations. This is the so-called root cause analysis that we often see in patient safety work and in other forms of quality improvement. If we do see gaps in quality, if we do see barriers to adoption of a new technology, a new innovation in healthcare delivery, or clinical treatment or prevention, we need to understand something about the barriers, the causes, so that we can develop a set of strategies that directly address those. If we deploy an educational strategy to try to change practice, but in fact education and knowledge are not the problem, the target physicians are very aware of what they should be doing. They simply lack the time or the staff or other resources. That solution, the educational strategy, is not addressing the underlying barriers. So we do need to conduct these root cause analyses. And then finally, feasible operational methods. And I actually alluded to these in reference to my last slide, and that is the need to have the staff, the space, the time, and the other resources that are available. So knowing what to do, having the motivation to practice in a way that's consistent with the evidence. All of the other conducive conditions may be in place, but if we simply lack logistical arrangements, we're not likely to see significant improvement in practices. So those are the key points that I'd like to make. Just to summarize, we need to see each of these elements in place to increase the likelihood of practice change. Our next two presentations will illustrate some of these points, but again, I would encourage you to use this sort of framework as a checklist in thinking through the different requirements for practice change and the different components of a strategy that would be needed to coordinate efforts from multiple stakeholders at multiple levels and try to overcome the full spectrum of barriers. So with that, let me introduce our next presenter, Dr. Alix Casler, who will provide one example of successful practice change in pediatric practice.
Thank you very much. You're a challenging act to follow. I am Dr. Alix Casler. I'd like to thank the CDC for offering me the opportunity to share our experience in process improvement and implementation science. My affiliations are listed, and I just want to take a moment because the why to me is as critical as the how. Just to remind everyone, and I know I'm preaching to the choir, but about why we're talking today. And I think that in any process improvement strategy, there really has to be the kind of boots on the ground, practical, why are we doing this? And it isn't because of the fee-for-service to fee-for-value conversion, and it isn't because the CDC tells us to vaccinate. It's because we have the potential to really change the lives of our patients, and we're not doing a very good job of it. So I think this slide speaks for itself. It's data that's acquired from the MMWR and comments made within MMWRs. And if we are able to achieve 3-dose HPV vaccination coverage to 80%, which is our Healthy People 2020 goal, it's estimated that we will prevent about 53,000 cases of cervical cancer over a lifetime of our patients who are currently 12 and under. So this is really why we're here. I do want to note to you that I do speak for both Merck and Sanofi. I'm very passionate about immunizations, and that is sort of the other part of my job aside from practicing and working in QI, or process improvement, I should say. My objectives for you guys today as you're listening to me talk is that you start to develop an applied implementation sciences approach or a real-world implementation sciences approach to your boots on the ground, translating the academic process of improvement concepts into real-life practice. And the pieces of that are going to be, first of all, to know what your rates are, not just what you think they are. And I'll get to that. Dr. Mittman mentioned evidence of deviation from recommended practice, know where you stand, and then setting very specific goals and identifying areas of weakness and opportunities so that you can establish a very firm aim. What do you want to change? How much? By when? How are you going to get there? Therefore, what's your portfolio going to be? And then remembering that whatever you implement has to fit into your busy life. And when you listen to the big picture of implementation science, it sounds very daunting. But if you break it down into your reality and your aims and your drivers, you actually can implement very, very simple, very effective processes that are sustainable, that are spreadable. And I'm going to show you how we did it in my very large group. We are one of the largest multi-specialty groups in Central Florida. We have 22 pediatricians in 11 offices. We have approximately 80 pediatric staff. And we service a patient base of 57,000 pediatric patients with over 23,000 patients 11 and up. We also are Level 3 NCQA Patient-Centered Medical Home Certified, which is a really nice honor, but also carries with it a tremendous amount of effort. So we have lots of competing realities. This is the slide that I showed my partners, and I know it's very busy. I apologize for that. In the middle of 2013, and if you look at the ages 13 through 17 row towards the bottom and compare it to the blue row of NIS teen rates, you will see that I was able to show my partners, as Dr. Mittman puts it, clear evidence of deviation from recommended practice. And it's really interesting because we are excellent providers, and all of my partners were shocked to see how poorly we were doing with respect to our NIS or our HPV immunization rates for both males and females, series starts and series completions. We were about at the Florida state level, which is, it's interesting to me that you're hearing from people today from Florida and Georgia. We're in the southeast, which is at the bottom of the heap. So we had to face the fact that we deviated from recommended practice as a starter. I do want to let you know that the reason I'm here today is that we were able to turn that around fairly substantially. And you'll see that I'm sharing with you rates of increase on a national level compared to our rates of increase over the same time frame. So I can tell you that putting Dr. Mittman's principles into clinical practice, and I wish I had done a better academic study of his principles, it would have made my job easier, but it is possible to really, really move the needle. So we did not use the rapid cycle iteration that's part of QI. We did use the broad, what I refer to as strategic parallel processing, which defined a package or a coordinated portfolio of changes within our 11 offices, and we really felt very strongly that we had to keep it simple so that it could be scalable from office to office and sustainable within our offices. The first thing that we did was know our data. Coverage rates were first reviewed with our department in a blinded fashion, so that slide that I shared showed department-wide rates. But after that first day, we became transparent to one another, and we shared our rates in a totally unblinded, transparent format, initially monthly and now quarterly. So each one of us knows how all of us are doing. We set very, very specific goals. We wanted to show improvement in our first year because we knew we were that bad. But by 2015, we set the bar at the NIS teen average rates for females for our entire population. So we wanted to move our boys up to the girls. And our current goal for 2017 is to meet the Healthy People 2020 goals. We're also shooting to meet this for all of our patients 11 through 18. So very, very specific goals in a time frame. So we definitely took on a lot, and we decided to map out a whole series of interventions. And I would specify that the first thing on our intervention list was to appoint a champion or a driver of the program. And then we implemented multiple pieces of this package, which I'm only going to explain a few of, and the rest of this list will be there for you to work or look at later. I'd like to talk about the physician and staff education programs because, as Dr. Mittman pointed out, physician education is not enough, but physician education was the start. As you know, physicians have multiple competing priorities, and one vaccine is very small on the list of priorities. But knowledge of the ubiquitous nature of HPV and the impact of HPV on our patient was a significant driver. And scripting and learning scripting from an educational provider, a physician who had great experience with talking about HPV, provided the skill that Dr. Mittman talked about. What we know is that patients will accept vaccines on about an 80% or better level if the physician says in a very clear way that they recommend it. So we looked for that skill. These classes were taught, there was a class for physicians that was an evening dinner program taught by a nationally recognized speaker who uses fabulous words and was able to reteach the physicians about HPV and also teach the physicians a script. Staff education programs took place in each one of our offices and educated every staff person who has any contact with a patient in the disease state, and in their role, they were empowered to participate in enrolling patients and participating in HPV immunizations. And the one big lesson that we got was that there's a huge resource in our staff. We did offer physician incentives. We are converting from fee-for-service to fee-for-value, but that's not a driver. Competition is a driver. Bottles of wine were brought in for physicians who did well on a month-by-month basis, and we do have a quality bonus structure. Again, money isn't enough, but an incentive is part of the package. We implemented the addition of HPV vaccines to our daily pre-visit planning. This is not resource intensive. This is not expensive. This is not fancy. This is what we do in each of our offices every day. We map out everything that every patient is going to get. As patients are added to the schedule, what they need gets added so that at check-in, the secretary and the MA all know what's going on. When my patients are roomed and when all of our patients are roomed, they already know what shots they're going to need and they already have the vaccine information sheets in hand. Many times our MAs have already sold the vaccine, if you will. We scheduled subsequent doses. This is a single click, very quick, very easy, so that second and third doses were scheduled before the patients left. Our secretaries are educated so they don't let people leave without their appointment scheduled. This prints out on their summary. Phone calls are generated as a result, so patients are reminded. They're tracked if there's a no-show or a cancellation. We also use nice manufacturer tools to remind patients of their follow-up visits. This made us commit to keeping our schedule open 6 months ahead of time, which was a change for us, but again, not labor intensive, simple. All of this is 1 or 2 clicks in the computer that guarantees that patients understand how critical these visits are. So these are our results, and you'll see that the little stars compare national rates to our rates. And again, if you want to review this in detail, it will be available later. But I'll tell you that the purple line up at the top is our female series starts. The next line down, male series starts. Red is female series completion, and blue is male series completions. This is as of July. We were at a 66% start rate for females, where you'll see we started at about 40, and vice versa. One of the things that we look at in quality improvement is balancing measures, what else went on. And you'll see that all of our immunization rates for adolescent vaccines went up as a consequence of focusing on HPV. What we did now, we looked back and surveyed our partners on what they felt were the most valuable portions of our program, including our education programs, scheduling of subsequent doses, utilization of tools, our transparency, competition, and bonus structure, and the involvement of staff. And we've now defined next steps for ourselves, which will be sustainability lectures in offices now 2 years out. We're reaching back to staff to retrain. We're personalizing prevention office by sharing rates with all offices within their office for the office staff. We're establishing local champions in each office. We'll be doing surveys of our highest performing physicians to share best practices. We'll be doing root cause analyses for those partners who wish assistance, who have lower rates. And we'll be working on another physician education program at the request of my partners in order to improve their scripting and their conversation. So for you as a takeaway, I would suggest that you define a champion who can share your rates and help you establish specific goals. I would recommend that education, although not the entire answer, is at the root of the spirit and the energy behind one of these improvement processes, and that you choose process improvement that will be sustainable and scalable within your organization. I'm going to pass this on now to Kia Redwine, who works in another southeastern state where rates started out very low and was able to implement a beautiful project within her organization at WellStar.
Thank you, Dr. Casler. Again, I have no disclosures. I do work with WellStar Health System, the medical group. Dr. Casler and Dr. Mittman have already done an excellent job of laying out the science behind it. And again, as Dr. Casler has done, this will be an example of a boots on the ground type of movement. In our offices, we have about 47 offices that administer the HPV vaccine. We have within our medical group what we call a pediatric cabinet and an internal med family practice panel. Both are forums for providers to discuss multiple issues included in the medical group with immunization rates. While looking at our Tdap and meningococcal immunization rates, our immunization rates here are actually very, very good. What we had to do in looking at that was realize we had an issue when it comes to HPV rates. We got with our immunization program consultant, our local one, her name is Noreen Dayhill, and if you don't have a Noreen Dayhill, you truly want to get one. She's been instrumental in helping us improve the rates for our offices, which has been phenomenal work in collaborating with her. Again, we quickly realized that although we were doing a phenomenal job with Tdap and meningococcal, we weren't doing very well as the rest of our region with immunization rates. The national immunization rates have been struggling, and if you look at the 2014 NIST summary, further confirms that information. Unvaccinated adolescent rates highlights the deficit for this cancer prevention vaccine, something we truly, truly wanted to push. And Georgia, unfortunately, has a distinction of being amongst the lowest in HPV rates. So this is an issue we wanted to champion for our communities for improvement. The first thing we do, we had to recognize the issue. And in recognizing the issue, we quickly realized we needed to form some partnerships to improve the rates. The partnerships we had, we worked with, or we had help with, from the Georgia Immunization Program, which worked with GRIT, which is our Georgia Registry of Immunization Transactions and Services. And this began in a campaign in October of 2014 to pilot an automated reminder system. This system would call or send text messages to parents of adolescents who were overdue for their third dose of HPV, and the message did not specifically state any identifiable information, but rather instructed the recipient to call their doctor or local health department to schedule an immunization appointment. We also want to get the staff involved and want to get them invested in the vision for improvement and make them a cornerstone of the solution. We had CDC EPIC immunization classes were scheduled for the offices to discuss all vaccines and allow the staff the opportunity to specifically ask questions on HPV. So we had to set some goals to get started. The first goal we set was a very conservative 5% increase annually. We really wanted to push the messaging of this being a cancer prevention vaccine to remove any of the parents' hesitancy towards the vaccine. So we have Dr. Gold in our system, who is the Vice Chair of Pediatrics and Chair of Quality and Safety. Again, wonderful to have team members that really want to jump in and help out and lead these challenges. He went out to practices where HPV rates were very low and discussed messaging with providers of how to present this information to parents, as HPV being a definitely required, necessary vaccine as far as the provider is concerned, and not just this other vaccine versus the ones that are required to go to school. Messaging included vaccines being the HPV vaccine being something that provider believed in and was really pushed as a cancer prevention versus a sex-driven vaccine. We included our clinical leads, which are the leaders that kind of lead our back offices. They were encouraged to attend the Immunize Georgia conference, and this is where they would go to hear discussions on HPV vaccines and get further information they could bring back to the offices. The clinical leads were also brought to a group COCASA training. COCASA is a CDC application where we could extract from our GRIT registry HPV patient, and they would put this into this COCASA application, and it would help to regenerate recall lists and give them vaccination rates for that particular office. This step was included for the office to give them more of an incentive to strive for improved vaccination rates. When you know your numbers, you can look for that improvement and get excited about when there is an improvement. So we utilize multiple avenues to improve immunization rates by reaching out to those on the front lines and those with best practices, and including those that have the educational background for the improvement. Vaccinating offices, clinical leads, providers, again, our local immunization program consultant, using the CDC website, and the GRITS, which is our immunization registry. All the offices receive messaging on how to discuss the vaccines for the providers. The clinical staff got information on how to answer those questions, also to direct those questions to the providers for further information. The offices had training on recalling patients to get them in for these vaccines as well. Clinical leads discuss with the front office getting patients in, so they would help with the recall list, which means you have front office and back office staff calling patients to get them in for those immunizations for HPV. Offices would submit the COCASA report for comparison. So all the offices would do their own COCASA, and then the reports would be gathered collectively so that we could discuss and look at those immunization rates. This drove truly a lighthearted, competitive nature for our offices that wanted to improve, and they would talk to other offices if there was an improvement. So not only were they looking at their own rates, they were looking at others. And if somebody was struggling, then you have a forum to offer assistance. So here's an example of a couple of our offices here. It's a visual that demonstrates where we are with a sampling of 3 offices now. So these are the 2014 statistics, if you will. In 2013, females receiving 1 or more doses was 53.7%, males being at 40.5%. So while we are not making a direct comparative observation here, one can see that the state has made some improvement in this area. These offices, and again, this is just a sampling, have benefited from the collaborative efforts of multiple professional approaches. Office A increased in its area by 12% in under 1 year. In 2013, Georgia had a completion rate of about 65.1% for females and 40.9% for males. Considering the same information, all 3 of these offices again showed improvement. This particular slide will demonstrate that Office B had an increase of about 21%. Part of the solution is recognizing missed opportunities and finding ways to decrease the amount of missed opportunities. Here, Office B had a decrease of about 19% in missed opportunities. Decreasing the number of missed opportunities is paramount in improving vaccination rates. Office A in this area, as you can see, did not decrease as well as the other 2 offices. Here's where this team collaboration was most utilized to gain improved results. Between our immunization program consultant, Lauren Dayhill, Dr. Gold, again, who is our Vice Chair of Pediatrics and Chair of Quality and Safety, and my department, which is Clinical Services, the officers were given multiple tools in messaging, pre-visit planning, and use of COCASA to know their actual immunization rates and get improvement. So just to recap on what we have here, the offices would pull recall listings monthly and strive to schedule well-child checks and nurse visits for vaccine improvement. HPV COCASA reports for all offices are shared quarterly with the pediatric cabinet and with the internal med family practice panel. Georgia Immunization, the Immunize Georgia Conference is attended for increased knowledge and compliance. A multi-professional team approach was used to start and to help maintain improvement. And our goal of an increase of 5% was surpassed, and another conservative goal of 5% over the next year has been set to promote this ongoing project of improvement. Again, our ultimate goal is to get to the Healthy People 2020 recommendations. Now I would like to turn it back over to the CDC.
Thank you so much. Thank you, Dr. Mittman. Thank you, Dr. Casler, and thank you, Ms. Redwine, for 3 great presentations. We're now going to ask 2 polling questions to kind of wake the audience up and to get some feedback on today's webinar, and then we'll move into the question and answer session. So the first question is, how helpful was the information presented during this webinar? How likely are you to use the information presented during the webinar? So much. We're now going to move into the question and answer session. And if you have a question, please type it into the chat function, and we will respond to questions as time allows. First question that we have, what are the HPV 9 efficacy rates? Any of the presenters can respond to that. The next question that we have comes from Emily.
I'm sorry.
Bannon.
This is Dr. Casler. Can you hear me? I think you couldn't hear me. Okay. For HPV efficacy rates, very specifically, I honestly would refer the listeners to the package insert. Efficacy varies depending upon which cancer and precancer you're discussing. What we know is that efficacy for cervical cancers and high-grade cervical lesions, as well as genital warts, is well in the high 90s in terms of percentages. As we get into vulvar and vaginal cancers, efficacy rates are a little bit lower than that, but very specific numbers are included in the package insert and are really easy to read.
The next question is, as pediatricians, how do you instill urgency in parents that say their kids are too young for the HPV vaccine to get them to accept recommendations?
I think that one's mine too. This is Dr. Casler, and I would preface my answer to this question by reminding you that, yes, I do practice pediatrics, and in fact, a bulk of my practice is people of very strong faith and children who are perceived by their parents as not being at significant risk for this disease. But I think the key is understanding that we don't need to front load this with the implication of impending sexual activity. This is a vaccine just like every other vaccine. And as I said, we had a colleague of mine who does the same kind of speaking that I do come in and talk to my partners. They didn't want to hear from me. They wanted to hear from someone who wasn't their bud. But we present this as a vaccine just like every other vaccine. We immunize with Tdap, hopefully prior to the time when we feel like a child's previous DTaP vaccines are wearing out, just to maintain immunity. We immunize with meningococcal vaccine at a time well before the peak in meningococcal meningitis rates, because we know that that's coming. And at 11 to 12 years old, which is when the CDC recommends routine immunization for all of these diseases, we know that the bulk by far of our patients are not at risk for exposure and not going to be at risk for exposure for quite some time. So it's not about impending sexual activity. It's about a lifetime of prevention, and this is a vaccine just like every other vaccine that we give. So our presentation is very straightforward. You're 11 years old. We're here for our shots today, and at 11 years old, there are 3 shots that we do. We do our first of the 2 meningitis shots. We do our first of the 3 HPV vaccines, and we do our Tdap booster. Do you have any questions? And then when parents ask questions, we answer in very unloaded, very straightforward immunization terminology that doesn't separate out HPV from any other vaccine.
We have a question for Dr. Mittman. Is there a publication that presents the framework or steps that you presented today?
No, not yet. There's some somewhat related publications that do talk about the different categories of barriers, and I'll pass along a list of those so that they can be distributed if desired.
I have another question asking, can you please provide the name of the national speaker that provided training and the script for physicians at your dinner event? And I believe that's for Dr. Casler.
Sure, I sure can. He's my colleague, Dr. Michael Brown, who works over on the west coast of Florida. He's well known as a speaker and has a gift with words, and offered my partners a number of really effective catchphrases. His favorite is, you don't put your seatbelt on while you're entering the freeway, you put your seatbelt on while you're still sitting in the driveway. And again, those are for patients who question the vaccine upon initial presentation and need a little bit more discussion.
Question. How often do you share the HPV coverage data with the clinic?
Yeah, you want to touch that one first?
Absolutely. For our offices, the offices themselves run the CACASA report monthly. So they're looking at it themselves for their own benefit every month. Every 3 months, all the offices look at their rates together, and that is what drives that competition of they get really excited if they improve, even 0.1%, if they improve by, 0.5%, and it's really that they can see that movement forward. So they see it on their own every month, and then every quarter it's the entire group.
And in our group, we did it monthly initially, and this is just one of multiple initiatives that we have going on in our system. we're driving multiple disease states as well as immunization rates. So we looked at HPV monthly when it was our new addition to our portfolio, and now we look at it quarterly as a group entirely, and then physicians take that back and share it with their staff.
I have two follow-up questions to that question. The first one is, how difficult was it to find a champion in the practices? Second one is, how did your leadership decide to take on HPV vaccination rates as a project?
Yeah, you want to go first?
I'll go first. Yes.
Honestly,
go. Once our leadership saw the vaccination rates for Georgia compared to ours, and we were below the Georgia rate, and Georgia is already amongst the lowest in the nation, it really was a no-brainer. We've got to get this cancer prevention vaccine out to our patients. It really goes back to safety and quality. So getting leadership involved was very, very easy. It's basically looking at the numbers. The evidence is there. As far as getting the offices to champion that, each one of our offices has a clinical lead. So they champion these types of projects. And again, as Dr. Casler said, multiple projects that every office works on. But they were the ones that spearheaded it. So they would get this information. The providers that get it at the pediatric cabinet or the IMSP panel, they would bring it back to the office for the providers. The clinical champions are running it every month, and they are discussing it with the staff and getting them engaged.
And I would add to that. I mean, I'm part of a very large group, but don't get me wrong, we're not made of resources. We still run our own practices and carry our own overhead and take home what's left over at the end of the month. So we're very regular docs. I am by far the champion of our quality because I've defined that as my career goal. And so fortunately, the hospital that we're affiliated with has offered me the opportunity to dedicate part of my career to that. So the only resources associated with this are my salary for my quality work in multiple venues. We chose this as a target because of the CDC emphasis. When the CDC comes out year after year in tears saying, what are we doing, what are we doing, and we looked at our rates and said, what are we doing, we decided that this needed to be as much of a priority as asthma, which is 10 to 15% of our patient base. In terms of establishing champions, what we did was we left an organizational champion for phase one, which was me, and I was the driver. But what happened was that as we converted from numbers to people and looked at, someone asked a question about HPV vaccine efficacy. And granted, the efficacy data that's in the package insert really has to do with per protocol efficacy. In other words, people who were all HPV naive when they started and did the series over the exactly perfect 6 months and stuck with it. So you can't apply those numbers directly to your practice, but in your heart you can. And so when our offices look at our 23,000 teenaged patients and look at the numbers of cancers prevented in the efficacy data and convert that to faces of our patients, what ended up happening was that champions evolved at every single office and took the reins, and those people now communicate. So we've got office managers in some offices, and we've got nurses in some offices, and physicians driving the boat in some offices, and it has now become a passion of very personal nature.
I have a few more questions. One question is, do you have the support of the school nurse when it's time to get the teens back into your clinic?
In our group, I would say that there's very little work with the schools at this time in Florida.
And I would say the same here. Definitely an avenue we want to improve, but at this time we would be the same as Florida in this situation.
One more question. How many staff did it take to train providers on COPASA and provide the provider education?
For the COCASA training, that was actually done with our clinical leads. So that was, again, Noreen Dayhill, which is our immunization consultant. She's the one who basically has our territory, and myself. So basically we set up, everybody came in, and we did one whole day of training at different times so they could fit it around their schedule. The actual training itself took about an hour and a half, but it was literally walking through, this is what COCASA is, this is the information you want to put in, these are what you're going to get out, and these are what the percentages mean.
Okay, one final question. We have heard that pediatricians are more likely to discuss vaccines and include them with routine vaccines than family practice providers. Do you have any special recommendations for improving family practitioner involvement?
So that's, I'm sure Kia can answer that. That's a really good question. It's in our group, because we started with our 22 pediatricians, the interesting thing is as enthusiasm has grown and we've gotten documentation of how well we're doing, the FP department has approached us for education and has approached us that they're interested in pursuing what we're pursuing at both the physician and staff level. So we will involve them in the sustainability lectures that are going out to each of our offices in the next 2 months.
And for us, basically, we get started with pediatrics in this area, then expanded to internal med and family practice. And they will be having the same COCASA training as we did for pediatrics. They will we will have different assistance from clinical services and, again, from the panel helping those providers getting acquainted with COCASA and getting those HPV rates up in those areas.
Thank you. Thank you, everyone, for today's webinar. Thank you for all of the audience members who joined us on today's webinar. If you have any more questions or want more information, please feel free to visit the CDC website at www.cdc.gov/vaccines/teens. We will be posting today's webinar presentation online, and we will notify all participants when the slides and the recording are available.